Hey everybody, welcome back to another video. So in today's video, we're going to talk about blood flow regulation in local tissues and systemic regulation. But before we do that, we have to talk a little tiny bit about arterial structure and total peripheral resistance because they are crucial in understanding the regulation of blood flow. If this video helps you guys, if you learned something from it, please consider liking, consider subscribing, and maybe leaving a comment. Without further ado, let's get into it. So we got to briefly touch on arterial structure and characteristic, just so we're all on the same page. But just for your knowledge, I've already made a video on this in the same playlist, so go back and watch that if you're interested. Now, when we talk about arterial structure, you have to know that there's certain cells that make up of this arteriole, and it has certain characteristics. So the innermost cell is called the endothelial cell, and this is actually the cell that is facing the blood. Okay, this is the one that is being faced by the blood, and this guy is responsible for doing many things, one of which is secreting certain factors like nitric oxide or endothelin that can regulate the radius of this arteriole. The other thing you'll see here is this basement membrane, which is common for all vasculatures. The other main cell type here are these guys, called the smooth muscle cells. These smooth muscle cells are extremely important. These are the regulators of the arterial diameter. And when they contract, they will cause vasoconstriction. When they relax, they will cause vasodilation. And we'll take a look at how that occurs in a little bit. And then, of course, the final layer is just some connective tissue layer, which is just made up of a lot of collagen type 1. Okay, great. So now we're kind of on the same page. Something else you'll notice in this drawing is that I have these sympathetic nervous system nerve terminals located on the smooth muscle cell, indicating that these smooth muscle cells are highly innervated, and majority of their contractile response is coming from the sympathetic nervous system activity, not only by the sympathetic activity, but majority of it. And another thing that I'll leave you guys with is that the arterioles are something called the largest resistance vessels, and that's because they offer up the largest resistance to blood flow known. And this is in part because of their well innervated smooth muscle layer. Now that we're all on the same page with what is the kind of general structure of this arteriole, we got to talk about what is total peripheral resistance, right? How is it contributing to this blood flow? Well, first things first, I need you to recall this equation, super important equation. Mean arterial pressure equals to the cardiac output times total peripheral resistance. Now, you guys should be pretty comfortable being able to move around this equation, okay? So, for example, let's say I wanted to solve for cardiac output. Well, if I wanted to solve for cardiac output, I would just do cardiac output equals to the mean arterial pressure over total peripheral resistance, okay? And this should look familiar to you guys. This should look familiar to you. This is actually another way of writing Poiseuille's law, okay, which was just flow equals to the change in pressure over resistance. Well, here's the change in pressure, the mean arterial pressure, or the pressure gradient, if you will. Here's the resistance, and here's cardiac output, okay, which is just flow, or you can write it as Q sometimes. Either way, that's Poiseuille's law, by the way, guys, so just remember that. Now, what if I wanted to solve for total peripheral resistance? Well, for total peripheral resistance, you would have mean arterial pressure divided by the cardiac output. Now, why am I telling you all this? Why am I actually drawing these out for you? Why am I telling you this? Well, I'm telling you this because you can derive a lot of important relationships between these, variables. And those relationships will help you understand how blood flow is being regulated. So, for example, let's take a look at some of these relationships that we can draw. What do you guys think the relationship is between cardiac output and total peripheral resistance? Well, all you'd have to do is just look at the formula that fits it best. Well, okay, if total peripheral resistance increases, cardiac output decreases, and vice versa. So we can say that the cardiac output is inversely proportional to the total peripheral resistance. Okay, what's next? What about cardiac output and mean arterial pressure? All right, we'll just look here. Cardiac output increases, mean arterial pressure increases. Boom. Direct relationship. Cardiac output directly related to mean arterial pressure. And trust me, these relationships, they will come in handy throughout the video. We're going to keep talking about them. What about mean arterial pressure and TPR? Again, look no further. If the TPR increases, the mean arterial pressure increases. Okay? So you're seeing these relationships already pretty easily. And again, we can write down mean arterial pressure and the TPR are directly proportional. Now, let's stop here for the relationships for a second. And let me tell you another formula that you have to know. So it's all good and fine to know that total peripheral resistance is going to, act on changing blood flow, right, by reducing it if it goes up. But what is it? And what are the contributors to it? Well, there is an equation for resistance itself, and it's R equals to L multiplied by N over the radius squared, not squared, to the power 4. Okay. So this is the actual equation that exists for it. Now, this is a simplified equation. This is actually stemming from the this equation, which is resistance equals to 8NL over pi R4. This is the actual equation for radius, but we're going to use a simplified equation just to make things easier for us, okay? Now, technically, there are 3 contributors to resistance, okay? One of them is L, the other one is N, and the other one is R. So what the hell are these things? Well, L stands for length, okay? R stands for radius, and then N stands for, N stands for viscosity, okay? So we're going to go through these guys in order, and we're going to see how do these things physiologically change total peripheral resistance. Okay, well, first thing is viscosity. What does viscosity mean? What is it referring to? Viscosity is really talking about the thickness of a fluid. So, for example, let's take an example of having this tube right here, okay? And I have another tube here. Now, in one tube, I'm actually pouring water, and the water is moving pretty fast, okay? And in the other tube, I'm going to pour honey. I'm going to pour honey. The honey is going to move much more slowly down this tube than the water. And that's because of its thickness. It's super viscous, okay? And you can see that if a fluid is viscous, it has a higher resistance to flow, all right? So that's what viscosity means. It's talking about the thickness of the blood. Now, when can you actually see viscosity? Well, there's 2 kind of scenarios where you can actually see viscosity, and so I'll add another arrow here. And the first one would be, for example, in anemia. You know, a person who has anemia, you know what their problem actually is? They actually have a low hematocrit. So let's take this red blood cell here, okay? Not red blood cell, let's take this blood vessel. In this blood vessel, I would have normally 1, 2, 3, 4, let's say, red blood cells. In somebody with anemia, guys, instead of having these 4, that's a normal number, they would have 2. And so their blood viscosity, does it go up or down? On somebody with anemia, the viscosity goes down. And if the viscosity goes down, what do you think is going to happen to the total peripheral resistance? Well, let's look at this equation. Well, this guy's on the numerator, and if this guy goes down, then this is a direct relationship. The resistance goes down. So you can see that if your blood is less viscous for many reasons, one being, for example, anemia, then you can actually have a lower total peripheral resistance. And if you have a low total peripheral resistance, we know that can have effects on your cardiac output, right, or your blood flow. Okay, what other things can affect this? So let's say instead of having low red blood cell count, I actually have higher red blood cell count. So we said 4 was normal. Let's say I have, this many. If I have this many, that's definitely more than normal. That is a disease called polycythemia. Okay, polycythemia, and this doesn't just happen with diseases. Okay, for example, if you start blood doping, right, red blood cell reinfusion, or taking EPO, all of those things can endogenously increase your red blood cell production and increase your blood viscosity, which obviously is not good. So for people with polycythemia that have high red blood cells, okay, these guys have low red blood cells. For these guys, it's actually the fact that they have a high viscosity and they would have a high resistance. And of course, they would have a low flow. Okay, so that's good to know. What is the other parameter? I'm going to skip over radius for a second, and let's just focus on length. Length really is pretty self-explanatory. It's referring to the length of the blood vessel. All right, so the length of the blood vessel, which can be affected by height. So let's take two people. This guy right here and this guy right here. Which one of these guys do you think has the bigger length of blood vessels? So look at this guy's blood vessels runs from here to here, whereas this guy's blood vessel runs from there to there. This guy's blood vessel runs from here to here, whereas this guy only from here to here. So you see what I'm saying, right? The taller the individual, the bigger the length of their blood vessel needs to be. And that has implications because, think of it like this. I have this one tube, right? And I have another tube. Which one would it be easier to push blood through? This guy or this guy? Obviously, it will be easier to push blood through this guy because it requires less effort. With this guy, it's so much harder to push blood through, and that's primarily due to the friction that is going to be experienced along the way. All right? So because this length is higher, there will be a higher friction, which means there will be a higher resistance. Okay? So that's what mainly is the problem with length. Now, I'll tell you something right now. In a physiological state, right, when we're talking about vascular physiology, do we really care about length of a blood vessel when we're talking about resistance? Not really. I mean, we care a little bit about viscosity because, diseases. But length, not really. It doesn't change. After you've hit puberty, right, nothing changes. Maybe some slight changes here and there, but nothing really changes other than that. The main thing, the main contributor to resistance, total peripheral resistance, will be radius, okay? By far. It is the main contributor by far, guys. And I'll tell you why. Look at this equation. What is this raised by? It's raised to the power of 4. Let's imagine that we have a value for radius as 2. If this is 2, then because this is raised to the power of 4, this will have a 16-fold effect on the resistance. So if let's say radius is decreasing by 2, that will actually have a 16-time reduction, 16-time increase in your radius, because you will see that radius and resistance are inversely proportional. So if my radius decreases by 2, because it's raised to the power of 4, that will increase my resistance by 16 folds. Okay? Now, what are the things that actually affect radius physiologically? Well, there are metabolites, right? Metabolites. So there are certain metabolites that are released, for example, by the muscle when we're exercising, right? Things like potassium, things like O2, CO2, and I can go on, talk about ATP, maybe even adenosine, right? All of these different things, they're all metabolites. Another thing is the sympathetic nervous system. That is the most obvious one. The sympathetic nervous system, once it becomes activated, it will release norepinephrine to vasoconstrict arterioles, and we'll look at that in depth. The other one is hormones, okay? There are specific hormones, guys. So, again, talking about norepinephrine and epinephrine, they can be hormones, as well as neurotransmitters like norepinephrine. The other ones would be vasopressin, and the last one is angiotensin 2, which is again part of that renin-angiotensin-aldosterone system that I mentioned. And we'll have a separate video on this. But angiotensin 2 is released mostly during low blood pressure scenarios, and its job is to try and increase your blood pressure by causing vasoconstriction. Vasopressin, as the name suggests, it presses on the vessels to vasoconstrict. Okay? Sometimes you might see vasopressin be called antidiuretic hormone. Okay? That's another name for it. Other things include paracrine factors. Paracrine just refers to molecules that act on nearby cells rather than hormones that actually circulate in the bloodstream. So paracrine factors include things like nitric oxide and endothelin, which, if you remember from the start of the video, I said are both secreted by the endothelial cells. And endothelin can cause vasoconstriction, whereas nitric oxide can cause vasodilation. And we'll look at the mechanism for this. But okay, those are the things that can affect your radius. Now, let's take one look at something here. Let's say I have two blood vessels, right? Blood vessel number 1, blood vessel number 2, all right? And they both have the same delta P, the same pressure gradient inside of them, okay? So that's constant. The only thing that is different between them is one actually has a small radius and the other one has a high radius. So you can see that here. Here's radius, here's radius. Which one of these guys is going to have a higher blood flow? Well, obviously it'll be blood vessel number 1 because its radius is super high. And if the radius is high, we know that's inversely proportional to the resistance, and the resistance goes down. And we know if the resistance goes down, what happens to the blood flow? Well, let's look at our correlations. If the resistance goes down, the blood flow goes up. There we go. Easy, guys. Super easy. Okay. Now, we actually call it a name where we have this blood vessel that is increasing in diameter, and we have another blood vessel that is decreasing in diameter. When the blood vessel increases in diameter, we call that vasodilation. Vaso meaning vessel. When the blood vessel is decreasing its diameter, we call it vasoconstriction. Okay? So the vessel lumen is constricting, right? This is the lumen. Okay. Now, remember I said we're going to pause here with the relationship so I can tell you that, this equation. So now let's actually unpause and take a look at some other relationships. So let's talk about the relationship of total peripheral resistance with those three factors that I just talked about. So the first one being length, second one being viscosity, and the final one being radius. And this should be pretty self-explanatory. You just have to look at the equation. The length is directly proportional to total peripheral resistance. So if the length of the blood vessel increases, the friction increases, and the resistance thus increases. What about viscosity? Well, if the viscosity increases, guys, we know again it's directly proportional, and that's going to increase resistance. The radius is actually inversely proportional. So if the radius goes down, the resistance increases. And if the radius increases, right, vasodilation, total peripheral resistance goes down. Okay, so these concepts are super crucial to understand for what we're going to talk about in these next slides. Now, we talked a lot about smooth muscle cell relaxation and contraction, and let's just go through a very brief overview of how it works. We'll have a dedicated video talking about smooth muscle relaxation and contraction in extreme depth. But for now, let's just look at a brief overview. So on this side, we're going to talk about relaxation, and on this side, we're going to talk about smooth muscle cell contraction. So let's take a look at the actual smooth muscle cell relaxation first. I'm going to zoom in on the interaction between these two cells here in this arteriole. Okay, so these guys here are the endothelial cells, and the cells that are above them are the smooth muscle cells, just like we talked about in the beginning of the video. Now, what ends up happening is, due to certain stimuli, these endothelial cells in black, they're going to take a specific amino acid that they have placed inside of them called L-arginine, and using a special enzyme called endothelial nitric oxide synthase, they are going to turn this L-arginine into nitric oxide. Now, if you're curious, there's other things in this reaction. For example, oxygen comes in here, and the amino acid citrulline leaves out here, okay? But for the purposes of this video, it's sufficient to know L-arginine will interact with the nitric oxide synthase and create nitric oxide. So this molecule, nitric oxide, is very important, okay? Look at it. It is going to diffuse outside of the endothelial cell, right? Passively go through the membrane because it's lipid soluble, and then it'll go and interact with the cell that was above it, the smooth muscle cell. And once it does that, it'll come and interact with this enzyme that is present inside of this smooth muscle cell. This enzyme is actually found within the cytoplasm. It is called, and I'm going to abbreviate it here, GC. It's called guanylate cyclase. Okay, so it's called what? Guanylate cyclase. And this should sound familiar to some of you guys if you've heard about adenylate cyclase before. It's a similar concept, really. The guanylate cyclase, it will take a certain molecule called GTP and convert that to a secondary messenger molecule called cyclic GMP. Now, remember, this was done because nitric oxide stimulated the activity of the guanylate cyclase, and once this guanylate cyclase became active, it took GTP, turned it into cyclic GMP. The cyclic GMP will go through some other biochemical pathways and eventually lead to smooth muscle cell relaxation. Once a smooth muscle cell relaxes, guys, eventually this can lead to the vasodilation of the blood vessel. Okay? So if enough of these smooth muscle cells start going through relaxation, what ends up happening is there will be a collective increase in the lumen diameter, right? So this diameter would then change, it would increase, and that would be because of vasodilation, which is really caused by these smooth muscle cells all relaxing. Okay, great. Now, can this signal just keep going on forever? No. So something has to get rid of this signal. Something has to terminate this signal. And I'll tell you what that is. That is caused by a specific enzyme. So this is another enzyme that is present inside of the smooth muscle cell itself. And this enzyme, I'm going to abbreviate it as PDE. It's called phosphodiesterase. Phosphodiesterase. And if you're curious, this will technically be type 5 present here. But neither here nor there. This enzyme phosphodiesterase, it will actually take this cyclic GMP, right, which was the guy that was causing smooth muscle cell relaxation. He will actually break that guy down and turn it into GMP, so guanosine monophosphate. All right? And, through certain biochemical pathways, eventually this GMP will get converted into GTP again. And this GTP will remain here ready until nitric oxide comes, stimulates the activity of this guanylate cyclase so that it can take the GTP and form cyclic GMP again, okay? And the cycle goes on. But that's how the smooth muscle cell vasodilation or relaxation response is working. Now, we can take advantage of this to treat certain diseases, okay? Treat or manage. And two drugs, we can say, take advantage of this system. But other drugs exist, obviously, that take advantage of this. The first one is going to be Viagra, right? And Viagra, more often than not, is given to people with erectile dysfunction, right? And, the problem there is that you actually lack the ability to bring blood flow, all right? And so that's going to cause the erectile dysfunction. But with this drug, this Viagra, it is going to help bring blood flow and mitigate the erectile dysfunction, okay? And we're going to look at how it actually does this. There is another drug called nitroglycerin, okay? And you'll see nitroglycerin more oftenly used to manage people with coronary heart disease. It's given to people who experience symptoms of angina, and sometimes given to people with myocardial infarctions. And you know, these guys both act through different mechanisms. So if we look at Viagra, for example, Viagra is going to lower cyclic GMP breakdown. And if you guys remember, I told you that cyclic GMP was being broken down by this enzyme called phosphodiesterase. So likely, Viagra is going to somehow inhibit this phosphodiesterase enzyme from breaking down cyclic GMP. And if you don't break down cyclic GMP, what does that do, guys? That actually leaves a lot of cyclic GMP to accumulate in the cell, causing a lot of smooth muscle cell relaxation and vasodilation. If you vasodilate, you're increasing the blood flow to the desired area, and thus lowering the actual erectile dysfunction. With the nitroglycerin, it's a similar thing. The goal is to increase blood flow, but you try to actually achieve this by increasing the cyclic GMP production. Okay, so one of them is lowering the breakdown, the other one is increasing the production. And you can see that nitroglycerin will most likely stimulate guanylate cyclase or increase its activity to produce a whole bunch more cyclic GMP, basically achieving the same effect. Now, this makes sense because, again, this is kind of given to people that have coronary heart disease or myocardial infarctions because they had some sort of blockage in their vessels that led to a low blood flow, which maybe caused a heart attack. So increasing blood flow to the area can help mitigate some of those dangerous symptoms. Alrighty, now let's take a look at contraction, right? So this was all the smooth muscle relaxation and some of the drugs that we can use to take advantage of that system. But how does smooth muscle contraction look like? Well, again, here's another look at a smooth muscle cell, a rather more elaborate look than what I drew. Here's the actual nucleus of it, and here's the cell itself. Now, when you look at the smooth muscle cell, guys, you're going to see all of these little, like, kind of bands and these little circles. But the real question is, what the hell is all of these things? Like, what am I actually looking at? Now, these guys are very special. So, unlike skeletal muscle and cardiac muscle that have sarcomeres, the smooth muscle cells do not have a sarcomere, okay? But they have this weirdly shaped arrangement of thick and thin filaments. So these lines that you see here, these guys are just a bundle of thick and thin filaments, okay? And you guys remember your thick and thin filaments or your actin and myosin. And these red guys here, these red little balls, they're actually called dense bodies. Dense bodies. And these dense bodies, guys, they act very similarly to the Z lines that were in skeletal muscle and cardiac muscle. And if you remember the Z lines, all they did was anchor the thin filaments. And so that's exactly what these dense bodies are doing. Anchor thin filament. Now, let's take a deeper look at this real quick. So here is a smooth muscle cell that is relaxed. You can see it's pretty laid out, right? It's big in size. That's chill. And you can see here's another smooth muscle cell, the same smooth muscle cell, in fact, that is now contracted. And you can see it's all kind of squished everywhere. But in order to understand how this happened, you got to take a look at the relaxed guy first and look at how these actual thin filaments are arranged. So take a look. Here's a zoomed in view of one of them. Here is the thin filament, okay? Here's the thin filament made out of actin, you guys remember. Here is the dense body, okay? And right here in brown is going to be the thick filament, okay? Which is made out of myosin. And if you guys remember, in order for contraction to occur, myosin and actin have to interact. So anything that is increasing the myosin and actin cross-bridge formation is going to lead to contraction, and anything that is decreasing the myosin and actin, cross-bridge is leading to relaxation, okay? So this guy, in order to go this way, we have to increase the myosin and actin cross-bridge, right? The X represents cross-bridge. If you want to go this way, you want to decrease the myosin and actin cross-bridge, okay? So how does this look like if I zoom into this interaction even more? Well, if you zoom in even more, now you can actually see the molecules, right? So again, you can see the helical actin, all right? And now you can see the actual myosin heads as well. The myosin heads are even oriented differently than, skeletal muscle and cardiac muscle, okay? And if you take a look here, what you would see is when the smooth muscle cell contracts, right? All of these guys you can see they're oriented kind of diagonally. It'll kind of smush the smooth muscle cell. Take a look. So initially, we had this long, elongated actins, right? But these thick filaments, they're going to remain where they are. And what they're going to do, guys, is they're going to pull this top thin filament this way and this bottom thin filament that way. And this myosin here is going to do the same thing. This guy that way and this guy that way, okay? And what you'll end up seeing is this, where this guy has been pulled this way, this guy's been pulled this way, this guy's been pulled this way, and this guy's been pulled that way, okay? You're seeing this kind of net smush effect occurring here, all right? And if you look into this, this is kind of what it's going to look like. You have the smooth muscle cells, right? Or sorry, the myosin heads, they're going to bend this way, this way, this way, this way, pulling the actin that's on top of them in this direction. And the bottom myosins, they're going to bend that way, that way, that way, pulling the the actins this direction, okay? And again, causing this kind of smushed look or contracted state of the smooth muscle cell, okay? Now, what are the things that make a smooth muscle cell contract? Well, we talked a lot about them beforehand. We talked about norepinephrine being one. We talked about angiotensin 2. We talked about vasopressin being one, right? Endothelin is another one. All right, these are all stimuli that can cause the contraction of a smooth muscle cell, which then lead to vasoconstriction, okay? So just like how we said, if all of these guys relax, we have vasodilation. Well, if all of them contract, we have vasoconstriction. Now, with all of that kind of overview done, let's take a look at, finally, what are the local intrinsic mechanisms that can control blood flow? And by local, I mean these are tissue specific, okay? So there's nothing systemic, there's no hormonal response, there's no nervous system response. These are just local tissue responses that can cause these effects to occur. But first things first, I would like you guys to recall something. I would like you to recall that an increased sympathetic nervous system activity, okay, will lead to an increase in heart rate and an increase in stroke volume, which will increase your cardiac output. The other thing I would want you to remember is that this increased sympathetic nervous system activity would lead to vasoconstriction, okay? And this will lower the radius of the blood vessel, which will increase the total peripheral resistance. And if both of these guys increase, we are increasing the mean arterial pressure. Now, keep this in mind because we're going to talk about this in the next slide, okay? So I just wanted to kind of remind you of that. Now, finally, let's talk about the local intrinsic control of blood flow. So first things first, there are multiple mechanisms where we can locally control blood flow. One of which, guys, is called the myogenic response. Myo meaning muscle, right? And then genic meaning stemming from or arising from. So this response, okay, this response is arising from the muscle. It's myogenic. What kind of muscle? Smooth muscle. Now, we tend to call this a selfish response, and you'll see what I mean by this. This is a selfish response. The myogenic response will allow for something called flow auto-regulation, okay? And again, don't worry if you don't understand this quite yet. We will look at it in depth here. Another thing you have to understand is that there are other mechanisms of controlling blood flow locally. The other one refers to hyperemia. Okay, so hyperemia. And hyper means high. Emia refers to blood flow. So high blood flow. There's two ways of achieving hyperemia. One of them is called active hyperemia. The other one is called reactive hyperemia. Okay? So these are strategically termed. Active hyperemia refers to a metabolite-driven response. So for example, you start exercising and you start building up metabolites in your bloodstream, and those guys will somehow cause an increased blood flow. Reactive hyperemia means that it is reacting to something, and that something is low blood flow, right? So in response to a low blood flow, we are going to somehow increase our blood flow to kind of cause a negative feedback loop on this, all right? Now, I've numbered these guys 1, 2, and 3 to correspond with these situations, these scenarios here that we're going to talk about, all right? So, without further ado, let's get started. First things first, we're going to talk about the myogenic response. So, let's talk about the myogenic mechanism. Now, technically, the myogenic mechanism can occur in 2 places. It can occur in the kidneys, and it can occur in the brain, but the brain is the simpler example to kind of go through here. Now, with the myogenic mechanism, guys, the myogenic response is really, really talking about, and it really starts with a pressure. Okay, so for example, let's take a scenario where I have high mean arterial pressure. Let's just say I got, hypertension, or I'm exercising or something, okay? I got high mean arterial pressure, and this high mean arterial pressure will, come here, right, and exert a large amount of force on the walls, the arterial walls of the brain vasculature, okay? Specifically the arterioles. Now, because this high pressure is coming into these arterioles and it is pushing on the walls of the arteriole, that will somehow cause a stimulation or an activation of these smooth muscle cells, and it will cause them to constrict. Okay? Another thing that is actually happening at the same time that I had high pressure, right? This initial pressure, you know what it's going to do? It'll push on these walls, it'll stretch the walls, increasing the blood flow to the brain transiently. So the blood flow to the brain will increase transiently. But remember, I told you that at the same time that this guy was stretching them, it was activating these smooth muscle cells to constrict. So if I take a look at this brain and the vasculature surrounding it like 5 seconds later, right? You know what I'm going to see? I'm going to see that those smooth muscle cells that became activated, they will have contracted and they will have caused a vasoconstriction response, okay? A vasoconstriction response where now the blood flow will actually, go back down to normal. Low blood flow back to normal, okay? Alrighty, and you know what that's going to do to the mean arterial pressure at the level of this arteriole? I'll tell you what it'll do. It'll lower it, okay? It'll decrease the MAP downstream, all right? Okay, but what the hell does this even mean, okay? So let's recap it. We had a high mean arterial pressure. The high mean arterial pressure came all the way to the arterioles of the brain, and it stretched the walls of the arteriole. When it did that, it transiently increased the radius, thus increasing the blood flow to the brain. But at the same time all that was happening, when we stretched the walls, we stretched the smooth muscle cells that are located in the walls. And that actually caused them to become activated and start contracting. And if I look at that same brain 5 seconds later, you'll notice that the blood flow of it goes back to normal. And that's primarily due to the fact that the smooth muscle cells on these arterioles contracted and lowered the blood flow downstream to the capillary, right, which feeds the brain, bringing the blood flow back to normal. You can now see how this is called a flow autoregulation due to the myogenic response. Now, why did I say that this response is selfish? Well, this response is selfish because, remember, I had a high mean arterial pressure originally, right? And what this guy did was he vasoconstricted, which lowers the mean arterial pressure downstream, but what's going to happen to the blood that was feeding this guy, it'll get kind of redirected. It'll get redirected because this arteriole vasoconstricted, right? And we know that arterial vasoconstriction increases total peripheral resistance, thus increasing MAP. But we just said the mean arterial pressure decreases. It does. It decreases downstream, but it increases upstream. So we call this a selfish response because this myogenic mechanism, it only cares about the health of the arteriole and how much blood is actually being fed into this tissue. All right? If it's too much, then it'll lower it back down to normal. But it does so at the cost of the mean arterial pressure. It'll end up increasing the mean arterial pressure indirectly. It didn't mean to do it, but it's kind of selfish. So it'll do it anyway. Okay, hopefully that makes sense. Now, the other responses are hyperemia. But just a quick thing. A lot of people seem to be confused about how does a stretch of these walls cause an activation of these smooth muscle cells. And I got a quick little sketch here for you, all right, where basically, let's say here is a relaxed smooth muscle cell, and here is a contracted one, okay? And this guy, they both contain something called a stretch activated calcium channel. So this is a stretch activated or sensitive, stretch sensitive calcium channel. So in a relaxed state, when I've not stretched the smooth muscle cell, you can see that the diameter of this, or this channel is not open. Okay, this channel is not open. But then, let's say I actually stretch the smooth muscle cell due to, for example, a high blood pressure exerting on the walls. This channel will now stretch and become activated, bringing in calcium. What do you guys know about calcium and a muscle cell? If calcium is inside of a muscle cell, it will cause the contraction of that muscle cell. Okay, so that's how that mechanism works there with the myogenic response. Okay, now we're going to talk about the hyperemic response, active and reactive. So with the active hyperemia, it's actually quite simple. Let's say that I have a normal amount of blood flow coming to my skeletal muscle capillaries. Okay, normal amount of blood flow coming to my skeletal muscle capillaries. But then, let's say I decide to start exercising. Okay, boom, 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 boom. I decide to exercise. My skeletal muscle is now super active. And once my skeletal muscle becomes active, it starts producing metabolites, guys. Metabolites. And those metabolites, you know what they are? It's those things that we talked about at the start of the video. The ATP, the potassium, the CO2, all of that. Those metabolites, they're going to come into this blood vessel here, okay? They're going to accumulate here a little bit. And because they're going to accumulate here a little bit, they're going to stimulate these endothelial cells to produce a special molecule that you guys have learned about. And that's called nitric oxide. This nitric oxide will then go and act on the smooth muscle cells that are located just above them and cause a relaxation and a subsequent vasodilation of this skeletal muscle arteriole. So that this normal blood flow will now actually turn into an increased blood flow because I ended up vasodilating. Okay? Now, why did I say I did this? Well, like I said, I started exercising, right? So this normal blood flow is no longer enough to the muscle. The muscle needs more blood flow to be able to, contract and bring oxygen to nourish the muscle perfectly well. So what the muscle does is starts releasing metabolites, right? As a result of increased metabolic activity in the muscle, we release these metabolites that will accumulate in the arteriole, and they will stimulate nitric oxide release, and the nitric oxide will cause vasodilation of this arteriole, which will then increase blood flow downstream to that capillary. All right? Great. Now, the negative feedback loop here is that the increased blood flow would kind of wash away these metabolites, right, that accumulated in here. And if there's no more metabolites, there's no more stimulus for these endothelial cells to make nitric oxide, and thus the vasodilation will stop. However, if you are going to continue the exercise, then there will be continuous production of metabolites and a continuous stimulation of nitric oxide despite the high blood flow. Okay? So that's active hyperemia, and it's literally just metabolite dependent. Reactive hyperemia is super similar, guys. It's super similar. But the best example of it is perhaps in the heart. So in the heart, during systole, what happens? What happens? Well, we know that there will be contraction of the heart, right? Contraction, 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 boom, 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 boom. But if I zoom in on the heart muscle, you'll notice that it has all of these kind of blood vessels running in between and through the muscle. And if the cardiac muscle is contracting during systole, it is compressing these vessels. Look at it. It'll actually compress these vessels, right? It'll compress these vessels, causing low blood flow to the actual tissue, causing ischemia, if you will. Very mild ischemia, very transient, brief. Now, this lack of blood flow will cause an accumulation of metabolites that is being produced by this contracting heart muscle, okay? Why is there going to be an accumulation of metabolites? Well, because these heart muscles are still contracting, but they're compressing the blood vessels that are supposed to wash away that actual metabolite. So those metabolites, they start accumulating in here. So look at this. Take a look at this. These guys, these muscles, cardiac muscles, they're going to start producing metabolites, right? The same ones that we discussed before. And those metabolites, they're going to, like I said before, accumulate in this vascular space, right? Like this, accumulating, and then they're going to stimulate the production of nitric oxide from these endothelial cells. And when these endothelial cells produce nitric oxide, they will actually go and stimulate the smooth muscle cells upstream, causing a relaxation of these smooth muscle cells and a subsequent vasodilation. But it's not that simple, okay? Let's take a look at this graph to understand this response a little better. So this right here is a graph describing aortic pressure above right here, which you guys know is during systole 120, during diastole 80, right? And here's the dichrotic notch. And this part of the graph in y-axis is about millimeters of mercury. This bottom part of the graph is describing the coronary blood flow, so the blood flow through the heart, right? These are your coronary vessels right here. And this one's in milliliters per minute, okay? So the coronary blood flow in milliliters per minute. And you'll see that as soon as I enter ventricular systole, the blood flow dips downwards, and it kind of remains impeded throughout ventricular systole, okay? So you can see right here, from here to here, the blood flow is super dampened as opposed to what it initially was, okay? And we can say that in this area, during ventricular systole, there is an increase in metabolite accumulation right here. Now, as soon as we finish with ventricular systole right here, and we enter ventricular diastole, what happens? We get a super increase in blood flow, the coronary blood flow. What is this part? What is this? Well, remember, if the metabolites start accumulating, what happens? They're going to stimulate the endothelial cells to produce nitric oxide, and the nitric oxide will cause relaxation of the smooth muscle cells. So why didn't the nitric oxide cause vasodilation during ventricular systole? Well, that's a great question, but it did. But the thing is, the vessels were still being compressed by the contracting muscles. As soon as those vessels relax, as soon as those muscles, the cardiac muscles relax and stop compressing these vessels, guess what's going to happen, guys? That reactive hyperemia is going to hit, and that burst of increase in blood flow will be seen, all right? And that's what reactive hyperemia looks like on this graph of coronary blood flow right there, okay? That part from here to here, when the ventricles are relaxing, is the increased blood flow. And this, by the way, is why I keep saying that the heart gets majority of its blood flow during diastole and not in systole, because in systole, the vessels are being compressed, metabolites are accumulating. As soon as the ventricle is going to diastole and relax and stop compressing these vessels, the reactive hyperemia response will hit, increased blood flow will happen, and the heart will get its blood. Okay? So that's everything with the local intrinsic control of blood flow in the tissues. All right, next we're going to talk about the systemic or extrinsic control of blood flow. And this one is controlled by two things, guys. It's controlled, and again, we've talked about all of this already. It's controlled by hormonal factors, or it's controlled by the sympathetic nervous system. And you know the sympathetic nervous system releases norepinephrine. Those hormonal factors are going to be, again, vasopressin, angiotensin 2, and norepi/epi. Okay? Now, how do these guys achieve their effects? Well, take a look at this diagram here, okay? When it comes to systemic control of blood flow, right, sometimes there are certain situations where you might want to take blood flow away from one organ and redirect it somewhere else. Or you might want to increase your mean arterial pressure, right, because you have like low blood pressure. So you take blood flow from certain organs and redistribute it to increase blood pressure. And you guys know that the mean arterial pressure is the number one homeostatically regulated mechanism. So let's take a look at this example here. Let's say I have a high mean arterial, let's say I start out with a low mean arterial pressure. Okay? I have hypotension, guys. Hypotension, low blood pressure. You know what my body's going to do? My body will activate the sympathetic nervous system, okay? And the sympathetic nervous system right here, here's a sympathetic nervous system neuron, will release a special chemical called norepinephrine. And norepinephrine can bind to two receptors, okay, that are present on the vasculature. One receptor is called the alpha adrenergic receptor. The other one is called the beta adrenergic receptor. Now, both norepinephrine released from the sympathetic nervous system and epinephrine released from the adrenal medulla, which we'll talk about later, they can both bind to either one of these receptors that are specific for them. However, these receptors, they have a special liking, a special affinity to only one of them. Alpha adrenergic receptors love to bind to norepinephrine, whereas the beta adrenergic, they love to bind to epinephrine. Another thing you should know is that in general, guys, in the body, in all of the vasculature combined, we seem to have more alpha adrenergic receptors, and I mean like a lot more, than beta adrenergic receptors. These guys are pretty rare in the vasculature, okay? Now, when I say that norepinephrine binds to alpha and epinephrine binds to beta, it's a specific isoform. If you want to know, norepinephrine binds to alpha 1 and epinephrine binds to beta 2, okay? Just remember, there is crosstalk. So, for example, norepinephrine can bind to the beta 2, but it's just weakly binding, okay? And it's not going to have as strong as an effect because the affinity between these guys is so strong. And the same goes for the alpha 1 adrenergic. Okay? So, how do you remember these affinities? Well, there is a cool and nice little mnemonic, I guess you can call it mnemonic, that you can use to remember. So, alpha, all right, the word alpha has no E. But you know what no E sounds like? No E, norepinephrine. Okay? Norepinephrine. There you go. So the alpha receptor has no E in it, and no E sounds like norepinephrine. So that's how you can remember what is the affinity of alpha receptor to norepinephrine. High. It's a high affinity. Beta actually has an E. Okay? And if it has an E, then it has to be epinephrine that it has a high affinity towards. Okay? So alpha, no E, norepinephrine. Beta has an E, epinephrine. That's how you remember which receptor likes to bind to which hormone. Okay? That's the affinity part. Now, let's get back to our discussion. I said that if you start with a low mean arterial pressure, okay, let's do that. Let's start with a low mean arterial pressure in this scenario. And if I start with a low mean arterial pressure, my body can sense that and it will increase sympathetic nervous system activity. And if we do that, if we increase the sympathetic nervous system activity, guys, you know what we do? We actually end up binding this actual neurotransmitter norepinephrine right now to the alpha receptor, the alpha adrenergic receptor on the smooth muscle cells of arterioles. So if you're not clear, these alpha receptors, guys, in pink, they are going to be located on the plasma membrane of these smooth muscle cells. And that's where the chemical will bind to. And when they do that, you know what they're going to do? They're going to cause a vasoconstriction response, guys. A vasoconstriction response. And the blood flow that was, for example, going to this GI tract will now become super minimal. And the blood flow will actually become redirected upstream. Okay? Why will it be redirected upstream? To try and increase mean arterial pressure. Let's look at other mechanisms that could potentially occur. So, similarly to the norepinephrine response, other molecules, other hormones, such as angiotensin II. Okay? Angiotensin II. All right? And vasopressin, okay, also called antidiuretic hormone, vasopressin. They have their own receptors located on the actual smooth muscle cells, all right? And if you're curious, technically, this would be a, for the vasopressin, it would be a V1A receptor, and for the angiotensin II, it would be an angiotensin II receptor type 1. 2 receptor type 1. But again, you don't have to know that, just out of curiosity. What will the vasopressin and the angiotensin II do when they bind to their respective receptors on smooth muscle cells? Well, they will do the exact same thing. They will cause vasoconstriction to occur, and that vasoconstriction will cause low blood flow to the organ that was previously getting a normal blood flow. Okay? And that's because we vasoconstricted the upstream arterioles and we redirected blood flow upstream. Great. And you know what happens when we do this, guys? We are going to cause an increase in the actual mean arterial pressure because we redirected blood flow upstream. And this right here is a classic negative feedback loop right there. Okay, so that's how you systemically control blood flow. Now, there is one more thing that I did not talk about, which was the beta receptors. And the beta receptors, they actually have a different function than the alpha receptors. So let's take this adrenal medulla here, okay, which sits on top of the kidneys. This is the gland that is actually going to be responsible for the production of epinephrine and norepinephrine. Okay, so this gland produces both epinephrine and norepinephrine. All right, so right here, boom, 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 and right here, boom, boom, boom. But we said that the beta receptor right here has a higher affinity to the epinephrine. So look, it's going to bind to epinephrine. And this beta receptor can be found in many different arterioles, one of which is skeletal muscle. It is said that they have a higher proportion of beta receptors as compared to other tissues. But if you look at the proportion of alpha to beta receptors in the skeletal muscle, they still have more alpha receptors, okay? So these beta receptors, if they happen to bind the actual epinephrine, they actually cause a vasodilation response of the arteriole, okay? And that might actually cause a redirection of blood flow into the skeletal muscle, okay, into the skeletal muscle. So those are the actual local controls. Now, one thing I do have to mention is a lot of people get confused as to how can the same hormone, epinephrine and norepinephrine, cause vasodilation or vasoconstriction? Because remember, I said norepinephrine can bind to both beta and alpha, and so can epinephrine. So how is it that they're causing vasoconstriction and vasodilation, but, like how? How are they doing that? Well, the answer lies in the fact that the hormone does not determine the action. It is the receptor they bind to that determines the action. Okay? So if norepinephrine binds to alpha receptor, you have contraction, vasoconstriction. But if norepinephrine binds to beta receptor, you have relaxation. Okay? Relaxation. But we know that norepinephrine prefers to bind to alpha because it has a stronger affinity for it, thus leading to a stronger contraction. Okay? So remember, guys, the effect of a hormone comes from the receptor it binds to, not the hormone itself. All right? Now, finally, this is the last thing we're going to talk about, guys. I know this is a long video. The last thing we're going to talk about is putting all of this stuff that we talked about together, the local responses, the intrinsic responses, and we're going to talk about how is it that we can regulate blood flow during exercise, okay? During exercise. This scenario that I'm about to talk about is very specific to exercise. So again, just another reminder that during exercise, you have an increased sympathetic nervous system activity, which causes generalized vasoconstriction all over the place. So everywhere gets vasoconstricted. Okay, remember that. That will cause an increase in TPR, total peripheral resistance. At the same time, sympathetic activity increases heart rate and stroke volume, which can increase cardiac output. Both of these values, if they increase, they can cause an increase in mean arterial pressure. But how can you make sure your mean arterial pressure doesn't get too high during exercise? Well, one of them, and we'll talk about more in the upcoming videos, one of the ways is that you guys know that the skeletal muscles, right, during exercise are working. They are active. And if they're active, their metabolic activity is high, which means they're going to produce a lot of those metabolites that we discussed. And if they produce a lot of metabolites, what kind of response are they going to cause, guys? They're going to cause the active hyperemia response. And if they do that, what are they doing? They are actually vasodilating blood vessels, a lot of blood vessels that feed the muscle. That can actually lower the total peripheral resistance a little bit and lower the mean arterial pressure. Okay? And that's what we're going to look at in these two big drawings here. Okay? So first things first, at the onset of exercise, and second things, during exercise. So at the onset of exercise, which by the way just means that as I start exercising, like I literally just stepped on the treadmill. Okay, I haven't started running it. I just started stepping on the treadmill, and I literally started moving a little bit. As you start exercising, remember your sympathetic nervous system activity goes up, and that is due to the exercise pressor reflex. And you know what that's going to do? That is going to cause vasoconstriction all around the place. So here with those sympathetic neurons again, boom, 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 they secrete norepinephrine, bind to the alpha adrenergic receptor in the GIT, rob blood flow away from there. And here is another sympathetic neuron releasing boom, 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 norepinephrine, which binds to its alpha adrenergic receptor in the kidney, causing vasoconstriction there. And surprisingly to everybody, norepinephrine being released at the muscle, causing vasoconstriction of those arterioles. And you might be confused. You're like, wait, aren't I like exercising? Shouldn't the arterioles be vasodilating? Well, you'd think so, but at the start, at the onset of exercise, I told you that the sympathetic nervous system causes generalized vasoconstriction everywhere, okay? And it doesn't discriminate. The only place that doesn't have vasoconstriction occur is the brain, okay? You can see there's no change in its diameter. The brain remains the same. And the reason for that is that there is a low abundance of alpha 1 or alpha adrenergic receptors in the brain, and that's why there doesn't seem to be too much of a sympathetic effect on the brain. Okay, so let's take a look here. Again, sympathetic nervous system, vasoconstriction of all of these guys. Okay, and if you remember, if you vasoconstrict guys, what happens to the blood flow in all these organs that was initially going to them? It'll become low. It'll become low. Okay, and it'll what? It'll start backing up here, right? Remember, we're vasoconstricted here as well, so the blood flow will back up from the GIT, the kidney, and the muscle. Okay, and it will work to increase mean arterial pressure. So that's what we've talked about so far, right? We increase the mean arterial pressure through this pathway so far, okay? And you can account for this pathway as well yourself. But the whole thing is we increase mean arterial pressure. Okay, and again, low blood flow here, easy. And again, low blood flow here. Okay, I'm not going to discuss this already. We talked about this so many times. Now, what happens once you continue exercise, during exercise? What happens during exercise? What changes? Well, first things first, we had a high mean arterial pressure now, right? So continuing during exercise, I will still have a high mean arterial pressure. So let's start with that. The high mean arterial pressure, right, if you guys remember, will have effects on specific tissues, like the brain. So look at it. It'll come to the brain, and that high mean arterial pressure will do what, guys? It'll stimulate, not stimulate, it'll stretch the walls of the arterioles feeding this brain. And you guys remember that initially, when I stretch these walls, I will briefly increase blood flow to the brain. But then what happens? Then these guys will become stimulated. They'll become stimulated, and then they will contract, right? Vasoconstrict, myogenic response, right? And they will what? They will lower the blood flow back down to normal. Okay? So this is how the brain handles the increased mean arterial pressure during exercise, right? By going through that myogenic mechanism. All right. What happens when this guy vasoconstricts? He will redirect his blood flow. Okay. Where does he redirect his blood flow? Give me a second. We will see. Now, what about these other organs? Are they going to be contracted or not? Yes. Look at the kidney. Look at the GIT. These are non-essential organs during exercise, right? Do I want to have blood flow go into my kidney or to my GI tract during exercise? No. So what I'm going to do is I'm going to activate the sympathetic nervous system, right? And guess what? Let's change colors back to normal, right? Sympathetic nervous system, and release those norepinephrine molecules, which will bind to the alpha receptors on the smooth muscle cells of the arterioles in the kidney and in the GI tract, and it will lower the blood flow to these organs, okay? Lower blood flow to these organs and cause a redirection of their blood flow, all right? So 2 organs of redirected blood flow, these guys and this guy. Now, where does all this redirected blood flow go? Well, one place it goes is the skin, okay? The skin. Believe it or not, during exercise, your skin gets an increased blood flow. Why does it get an increased blood flow? Well, it gets an increased blood flow, right? Because it needs to sweat during exercise. And sweating, if you guys know, can cause an evaporative cooling response to try and lower your internal body temperature. Okay? Because with exercise, your body temperature increases. So sweating is a way of cooling yourself off. All right? And so blood flow to the actual skin increases. And that's because the smooth muscle cells of the skin, the arterioles in the skin, they start to dilate during exercise through some unknown mechanisms. We don't actually know why that happens, okay? There's very little research on this. Now, the other place that will get a major increase in blood flow, as you would expect, would be the skeletal muscle, guys. So look, the blood flow that we redirected, it will come into the skeletal muscle. Why would it come into the skeletal muscle, okay? Why? Well, remember, and I can also add that blood flow may be coming from upstream as well, that will get distributed into the skin and the skeletal muscle. But why? Why are we having an increased blood flow to the muscle? Well, it's two things. One of them could potentially be the epinephrine being released from the adrenal medulla, right? Going and actually binding to those beta receptors present on the smooth muscle cells of the skeletal muscle, which will cause a vasodilation response. Okay, one of them could be that, but that's not very likely because I told you that these beta receptors are pretty, far and few in between. The main thing that is going to be responsible for this increased blood flow or redirection of blood flow to the skeletal muscle is going to be the active hyperemia response. So look at this, the skeletal muscle, right? It is active. It is active. Boom, 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 boom. It is producing a whole bunch of metabolites, okay? And those metabolites, if you guys remember, are going to come here, accumulate inside of this arteriole, and they're going to stimulate the endothelial cells there to produce nitric oxide. And the nitric oxide will then stimulate the relaxation of these smooth muscle cells, causing vasodilation. That is active hyperemia, and that causes the vasodilation of the actual blood vessels that are inside of the skeletal muscle, and those blood that was being redirected will go ahead and find their way into any open blood vessel that they can go to, and those open blood vessels are going to be the ones that are in the muscle and the ones that are in the skin. Okay, remember that. Anytime the blood gets shunted away from somewhere, it is just following its route to another open area. Okay, think of like driving a car, right? I'm driving my car here, but and I have all these options to take here, maybe here, maybe here, maybe here. However, now let's say I'm driving my car, but this avenue is knocked out, this one's knocked out, this one's knocked out, and only these two are left remaining, then I have the option to only take these two. Okay? So that's exactly how the blood is moving. Alrighty. Now, what happens when these two blood vessels vasodilate? Well, they're going to cause a lowering of the mean arterial pressure, okay, just like we discussed in this bit here, just like we discussed here, right? They're going to cause a lowering of the mean arterial pressure so that the mean arterial pressure doesn't stay too high, okay? And that's kind of an indirect mechanism that occurs when the skeletal muscle just wants to get its metabolites. Okay, not metabolites, it's blood flow, okay? So again, show increased blood flow to the muscle, right? Now, this actually has a name. So sure, it's called the active hyperemia response, but really, you can see that before the exercise bout, the sympathetic nervous system vasoconstricted my arterioles. But then I continued doing exercise and the active hyperemia overrid the response of the sympathetic nervous system. That's what's happening. So we can say that active hyperemia, okay, overrides sympathetic nervous system activity. That has a name. That's called functional sympatholysis. Pretty cool name. So sympatho referring to the sympathetic nervous system. Lysis means to cut. So you are cutting the sympathetic response because of active hyperemia. Okay? Cool. Functional sympatholysis. All right, guys. We have finally reached the end of this video. I'm so sorry for it being so long, but we had to get through a lot today. If you actually made it to the end of this video, you're a trooper, and I appreciate you a lot for watching. And, if you truly learned something, if this cleared up a lot of confusions from you, consider commenting, liking, subscribing, and I'll see you in the next video.